Welcome, everyone. Thank you for joining us for another episode of MASH Masters, where we will be discussing the interdisciplinary management of MASH. I am your moderator, Dr. Naim Alkhouri, Chief Academic Officer at Summit Clinical Research and the Director of the Steatotic Liver Program at Arizona Liver Health. And I am joined today by Dr. Jay Shubrook, who is professor and diabetologist at the Department of Clinical Sciences and Community Health at the Touro University, California College of Osteopathic Medicine. Welcome, Dr. Shubrook, and thank you so much for joining me.
Oh, thank you so much. Delighted to be here.
Thank you. So let's get started. If you can tell us who is at risk of metabolic dysfunction-associated steatotic liver disease, MASLD, and metabolic dysfunction, steatohepatitis, or MASH?
Yeah, I think this is so important. This is probably the most common condition your patients have that you may not know of. And so I think this is important for us to know about it. In primary care, most of your patients are at high risk. Those with type 2 diabetes, those who have evidence of metabolic syndrome or have central obesity. And I think it's really important for us to think about that signs and symptoms are not the way to find this, because most people have no specific symptoms. And if they are, they're often later. And we know this because many people, up to 2/3, are actually found out incidentally at the time of cirrhosis, which of course is what we want to prevent in primary care. So I think it's really important for us to think about this as a common condition in our practices, and we're going to have a strategy to find these patients.
Yeah, these are very important points. And I did a study when I was at the Cleveland Clinic where we asked people coming to be evaluated for liver transplant with the underlying etiology being MASH. And we asked them, did you know that you had any chronic liver disease before you presented with decompensating event? And it was almost identical statistic. We had 68% that they said they had no idea they had any chronic liver disease until they developed ascites, variceal bleeding, and encephalopathy. And this is really what we want to prevent, because it's not fair, because we have interventions today that can actually prevent these complications from happening. So speaking about the more advanced disease and mortality and causes of death in patients with MASLD, what are the leading causes of death in this population?
Well, I think many times we're thinking about MASLD, we're thinking about the liver. And of course, if you go to number 4, hepatocellular cancer, and number 3, cirrhosis, are those liver endpoints, and they're very important. But relevant to primary care, most people who have MASH will die from cardiovascular disease, the risk is doubled, or non-liver cancer. And so we actually have to think about that this is a systemic disease that affects the whole body, not just the liver. It's just the liver gives us insight of this inflammation.
Yeah, I couldn't agree more, and I'm glad that you brought up non-liver cancers. We have a large study from the Mayo Clinic that actually showed that patients with MASLD have increased risk of GI cancers, including colon cancer, pancreas cancer. So I always tell my colleagues, we cannot be too focused just on the liver. This is exactly as you said, it's a systemic disease that affects multiple organs, and we need to be vigilant in managing the cardiovascular risk factors, but also make sure that we do a good job with cancer screenings and just following the recommendations. All right, so we know that MASLD is a spectrum, right? And we have patients that have no fibrosis or early disease, and then we have patients that have MASH with significant fibrosis, and of course we have patients with cirrhosis. So what are the risk factors in these patients that actually have the progressive form of the disease?
Yeah, and I think it's really important to identify that we should not be lulled in that just lots and lots of people have the common colloquial fatty liver disease. That's not a benign process, and it can progress. And on our watch in primary care, we can identify and prevent it. And those who are at highest risk are listed here. Again, some of the same people: patients with type 2 diabetes, those with established obesity, those who have metabolic syndrome. There are also very important factors otherwise. Cigarette smoking is a driver for worse outcomes, as is recent weight gain. And so I think when we're thinking about these patients, we really need to recognize that this is not just, all part of the same thing. We really need to identify that there could be bad things going on here and that we can prevent them. Now, I know there's emerging risk factors. What are some of those?
Yeah, thank you for asking. So we know that patients living with HIV are at higher risk of developing steatotic liver disease, and actually they're at higher risk of developing the progressive form of the disease. Also, patients with hypothyroidism, there's disconnection between low thyroid function and MASLD. Patients with obstructive sleep apnea, very important to ask if they have snoring, if their quality of sleep is not good, because obstructive sleep apnea can lead to more progressive disease. And actually, we have data showing that treating the obstructive sleep apnea can improve liver enzymes and potentially liver stiffness. So very important to treat this potential comorbidity. Also, polycystic ovarian syndrome. These are typically younger women with insulin resistance, hirsutism, and these patients can develop MASLD and MASH even with normal BMI. So it is my practice to screen for MASLD in all women with PCOS. And finally, we are identifying some genetic variants that can lead to the development of MASLD, but more importantly, to the development of MASH and progressive fibrosis. And the most validated genetic variant is called the PNPLA3. I like to call it the pineapple gene, easier to remember, pineapple PNPLA3. And this is actually the variant associated with MASLD is more common in Hispanics, Latinos, and that's why they have higher burden of MASLD. But since the identification of PNPLA3, we've identified other variants like TM6SF2 and MBOT7. These are risk variants, and we have actually some protective variants like HSD17, beta 13. We are able to test for some of these variants in our clinics now, so this is becoming part of what we can offer to the patients. And I do this sometimes when there's a very strong family history of MASH, especially if there's progression to cirrhosis. So in addition to the classic risk factors, diabetes, metabolic syndrome, again, HIV patients with certain endocrine disorders like hypothyroidism, PCOS, obstructive sleep apnea, and some genetic variants are what we call emerging risk factors. So back to you, Dr. Shubrook. So we talked about the disease being progressive. We care the most about identifying patients with MASH and significant fibrosis. How do we find these patients in your practice, especially in a primary care setting?
Yeah, and I just want to reiterate that we have to do risk screening in high-risk populations. You know, this is not something they're going to present with a symptom or a sign with. So we do have very good evidence that there are ways that we can do for this. And we have the tools, and quite honestly, we probably already have the results in our practice today. So what is agreed upon as an initial screening tool is screening those people at high risk with a tool called a FIB4 calculator. This is something you can get on the AGA website. You can get on MedCalc. We actually have it embedded in our EMR, so we actually get it calculated immediately. But basically, you're looking at a patient age, an AST, an ALT, and the platelet count. And by doing this, you're able to calculate a FIB4 score. And this now historically has been low, intermediate, and high risk. We're going to be breaking that into low and high risk. And why this is so important is that you can calculate this in your practice and very quickly know, does this person need additional attention for MASLD or MASH, or is this someone that you can continue to do the metabolic management you're doing already? And so this is a very quick switch for us to be able to highlight and start to move forward. And so again, you have these values already, and probably labs you're already ordering, and you can calculate this and you can actually have it automated. So there are guidances that actually take this a step further. And so when we think about the clinical care pathway, this is the older version of the clinical care pathway. We will have a newer one coming out in the next 90 days, but I'll highlight the similarities. First of all, if you start at the top, we should be not waiting for elevated transaminases or incidental finding of steatosis on a liver to be our entry point. That is an entry point, but that's incidentally found. we should be proactively looking for those patients we mentioned earlier who have type 2 diabetes or factors of the metabolic syndrome, screening them regardless of their labs or their imaging, and then looking at this FIB4. And I can tell you, for those less than 65, a FIB4 less than 1.3 is considered low risk. That does not mean zero risk. That means low risk for liver-related complications. You can continue to do your cardiovascular risk management, your diabetes management, your obesity management. However, if that FIB4 is above 1.3, that could be an indicator that there's a bigger problem. And based on the guidelines to make sure we are very efficient about our referrals, a second test is recommended in that group, and that's usually a VCTE or FibroScan. Or if you do not have access to a FibroScan, you could consider ELF testing. And so what this does is it confirms those indicators based on that initial FIB4 that this person may be at higher risk. And this is very important because I know that before I utilized this clinical care pathway, I was sending lots of people based on transaminases to hepatologists. Since I've used the clinical care pathway, my referrals have gone down dramatically, but my specificity is very, very high. These patients are getting to the hepatologist so they can get potential treatments and prevent advanced complications.
Yeah, thank you for this excellent overview of the clinical care pathway. I couldn't agree, and I think one of the key messages is sequential testing, starting with FIB4, then doing a second test. If the second test is also showing high risk, these patients have very high chances of having MASH with significant fibrosis. And for me as a subspecialist, I want to see these patients because these are the patients that can qualify for resmetirom, potentially some newer therapeutic agents. So we can actually potentially reverse the disease, and we have data showing fibrosis improvement with these new agents, and also we can lead to MASH resolution. And the big picture is that we want to prevent progression to cirrhosis and all the liver complications that we discussed. So we've been saying that MASH is a systemic disease and it affects multiple organs. So that leads me to think that we also need a multidisciplinary team to manage the disease. So who are the key players in a multidisciplinary team?
Well, we need all of us. I mean, that's the short answer. I think we need to have the space in primary care to be doing evidence-based screening for these patients, not waiting for symptoms or complications. Then we want to partner with our other specialists in gastroenterology, hepatology, and endocrinology to say, hey, how do we work together in these patients? How do we optimize treatments and diabetology? And so wherever you're at in the spectrum, we have a role. Even the patients I'm going to refer to you for advanced liver treatments, I have to be very vigilant to continue to work on weight loss. I have to work on cardiovascular risk reduction and managing their metabolic disease. So we don't hand off the baton and let it go. We now work in conjunction together to really optimize the care for our patients, which is good not only for those liver outcomes, but cardiovascular and other cancer outcomes.
And I do believe that a primary care provider should be at the center of the multidisciplinary team. You guys are the maestros that really coordinate the care for these patients. And I'm glad that you are taking ownership of overseeing their care because they do need to see multiple subspecialists. And we need you guys to make sure that all the comorbidities are managed properly. Thank you so much for this excellent overview. I really enjoyed our conversation, and I hope it was educational for our attendees. If you want to learn more about MASH clinical advances, please visit the webpage that's demonstrated here on the slide. This program was supported by an unrestricted grant from Madrigal Pharmaceuticals. Again, I thank you for your attention and hope that you will join us in the next episode of MASH Masters.